part of the toxicology task force in paraquat poisoning in India. So, what I today with this lecture plan to do is not to give you antidotes of 100, 200 poisons that we all deal with. You have that in your textbooks. I'm sorry, am I audible to everyone?
Yes, yes.
Yes, you are Alaukik. Yes.
So, I don't plan to give you a number of antidotes for the vast number of poisons that we encounter daily. You have your textbooks for that. Uh, m- what I want to do today with this lecture is to give you a foundation of managing any poison or any patient that walks into your ICU with a poison in the middle of the night. And uh, I hope by the end of it, you'll be able to treat it with confidence. Is my slide visible?
Yes.
Yeah, your slides are visible.
Okay. So this is, of course, the statistics have been taken from online. But if you can see, there are more than 2 million hospitalizations globally with almost 200,000 deaths. That is the WHO 2023 data. Our problem, snakes, agricultural chemicals, this is our problem. Be it exams, especially in exams, if you are not able to know the management principles about your organophosphorus, alpha paraquat, and if there is a toxicology station in the exam, I don't think anyone is clearing it. You have to know the common poisons in our country, which is snakes, OP, alphas, paraquat. Uh, there is a rise of benzodiazepines and opioids, especially in the urban centers. And I'm sure most of you have also come across corrosives, acids, alkalis in your day-to-day practice. Uh, but if you see the right-hand side statistic, the mortality in general, this is not specific to any poison, but in general, with good ICU care, the mortality comes down to barely less than 10%. And most of the deaths are preventable. How we proceed with this lecture is I've divided it into two parts. One, the part A would be the foundation, the identification of the toxidromes, the basic diagnostic approaches, and the elimination methods you have. And then we'll talk about the Indian context, which most of your Western textbooks will not cover. Please put your doubts or comments in the chat section, and I'll try to answer them uh, during the presentation. And I'll take questions in the end. So, how toxins essentially will harm your patient? You have to know, if you understand the mechanisms behind the toxin per se, you will be able to, or you will be able to try to treat that poison. So first, these are the four main mechanisms. First of it is receptor mediated. Uh, there is a drug that either activates the receptor or blocks the receptor. And what do you have to do for it? You have to find an antidote. So your naloxone works because you are out competing the opioids at the receptors. Your flumazenil will work because at GABA A, you will be out competing the benzodiazepines, right? So these are receptor mediated toxins. The other mechanism is enzyme inhibition. OPs, they'll block your acetylcholinesterase. Methylone will block alcohol dehydrogenase. Some of them have reversible blockade. Some of them have reversible blockade and then turn into irreversible blockades, which we will talk about in few slides later. Then there are toxins that cause metabolic interference. Your cyanides, your alphas. Basically, they disrupt the electron transport chain. So most of them, they don't have antidotes. The best care is the supportive care and the timely care that you can give for such poisons. And then there are poisons, your paraquat and your paracetamol, which will cause direct tissue damage. See, while your paracetamol does have an antidote, most of the poisons in this category also do not have an antidote. Here also, time is of the essence, and they can turn really nasty if not acted upon quickly. This is the diagnostic framework. You want to take a picture of the slide, take it. Remember, it is sequential. You can't, and not simultaneous. First, and of course, in the ICU, you have one or two colleagues of yours who are going to help you, but you have to question the family if you can't question the patient in concern. You have to sit down with them, you have to probe them, you have to ask them about uh, what did they take, how much was it taken, how many tablets, how much dosage, how much grams of powder, whether they have any empty bottles lying around. Uh, you really have to play CID in these cases. And why? Because what my experience says is it's never one. Most of the time, when you encounter OPs, and I worked in centers wherein OPs come with co-ingested alcohols. So you have to manage both, right? And the management changes. So someone has to sit down with the family, note it down on paper. You have to calculate the milligram per kg dose taken because that is what will manage your patient effectively. Then you should proceed for your physical exam. Look at the vitals, look at the pupils, and touch the patient. Look at the skin of feel the skin of the patient. I'll talk about it in few slides. Uh, but do not forget to touch the patient with the toxin. You have to send certain basic investigations in all suspected poisonings. Your ABGs, your lactates, your blood counts, your entire metabolic panel, RFT, LFT. Do not forget to check for sugars. If the poison is not known, send for paracetamol and salicylate levels. Do your ECGs. Look for QRS interval, whether it's more than 100 milliseconds. QRS interval of more than 100 milliseconds is sodium channel blockade, and you have to treat it with sodium bicarbonate, no matter what the cause, no matter what the toxins. And you will see a dramatic increase in improvement of, like, sorry, dramatic improvement in hemodynamics with this. Then, if you know the poison, uh, send for your cholinesterase levels, do your whole blood clotting time, uh, do send for your urine drug scheme. There are some centers who do a 12 drug panel, there are some who do a 9 drug panel. There are fallacies of it, so do not rely on it. Uh, your urine drug is just going to confirm your uh, diagnostic part of it. It is not going to give you any diagnosis. Then again, and I want to stress upon this, the 9 and the 12 drug panel do not cover most of the poisons that you might encounter in your practice. Your TCAs are not covered in urine drug screens. You're never going to, you have to ask for specific assays. Most of the times, the patients will not be able to afford, and probably at 2 a.m. in the night, you're not even going to remember to ask for a specific assay. It's not done in every lab, it's not done in every center. So relying just on urine drug screen, you're probably not going to help your patient. Uh, in case of an unknown poisoning, your ABCDE comes first. That is a blanket rule for every patient that walks into your ICU. There is no point in trying to find out the poison if you've not intubated a patient with a low GCS. So look at your airways, get your IV access in place, put the patient on continuous cardiac monitoring. If you see an active arrhythmia or seizures, treat them. Stabilize the patient, stabilize the vitals before you proceed to do anything else. And this is a step you have to follow. So the next step is look at the vitals, look at your pupils. Myotics, it's either OP or opioids. Mydriatics, they're either sympathomimetics or anticholinergics. And then look for the toxidrome features. You have to read on the toxidrome features. Uh, One practice I follow over the years is every time I encounter a poison, I read about it. I've been doing this for over a decade, and I would suggest every one of you do it. You will be surprised how much you miss every time you see the same toxidrome in your practice. Uh, there is something called as coma cocktail, which is 25% dextrose, zero point 0.4 mg of naloxone, and thymine of 100 milligrams IV. But give your thymine before dextrose. Anyone cares to tell me why should that be done? Why thymine before dextrose?
Thiamine will help the glucose metabolism to go through the Krebs cycle, and
What are
that
you
will.
trying? What are you trying to prevent?
Vernix encephalopathy.
Hypoglycemic injury to brain.
Vernix. Good. So this is your coma cocktail. You don't know the poison. Your patient is not waking up. Uh, I'm sure most of you have encountered this in your practice. सब कुछ किया patient के साथ, but sugar check नहीं किया. So check your sugars, right? And give thymine. It's not going to harm. No one has ever received any harm from over thymine doses, right? If you are a center that receives too many poisons annually, you know, try to keep this in your cards. Flumazenil is not part of the coma cocktail. You have to remember that. Flumazenil use also comes with its caveats. This is the time when you wake up your consultant on call and ask whether or not to give flumazenil, right? You, we'll talk about it. These are the general management principles. As I mentioned earlier, your ABCDs first, stabilize the patient, treat the seizures and arrhythmias first, intubate the patient if needed. Have an honest communication with the family as to why you're doing it, what you're doing it. Decontamination principles. There are a lot of drugs and methods to decontaminate the patient. And then there are enhanced elimination routes. We'll talk about it. Then there are specific antidotes. There'll be a slide on it in the last. You can memorize it. But I want to stress upon this again. The best antidote is the good ICU care that you're going to give. For barely less than 10% of toxins, you're going to have specific antidotes. Even if you search online, even if you search the tox base in our country, uh, you might not get the specific antidote in hand. So good supportive care and quick supportive care is what is going to treat your patient. First, GI decontamination, activated charcoal. Dose 1 gram per kg, maximum 50 milligrams in a single dose. But remember the window. It is if the patient has presented to you within the first hour of ingestion. For some highly toxic agents, you can extend it to 2 hours, but not more than that. You are going to cause more harm than good. You're going to probably increase the absorption of the poison when you're giving it. It is absolutely contraindicated in an unprotected airway, in corrosives, and in hydrocarbons. And it is not going to be any use in your iron, lithiums, alcohols, and heavy metals. Right? So if you see a patient with alcohol and you're going to give activated charcoal, you're just wasting your time there. It is not going to help. You, I don't know, I've never used Ipecac, but you can never induce emesis. Don't give charcoal for corrosives. If you have a clear history of corrosive poisoning, don't blindly insert Ryle's tube and start pushing in that charcoal. Your gastroenterologist is literally going to be shouting at you if he's coming at in the middle of the night to treat that patient. And always give charcoal with a protected airway. If with airway, if in doubt, intubate the patient, then go ahead and do everything else. So remember, no induced emesis, no charcoal for corrosives, and not with unprotected airway. I am repeating this again and again because I see this happen every single time. People insert a blind RT and give activated charcoal. So don't do it. And it will work only within the first hour. Keep your auscultate your bowel sounds before every dose. There is a concept of multiple dose activated charcoal, which is 25 grams every 4 hourly. But the indications are very precise. Take a photo of it. It is only for these drugs. You're basically trying to interrupt the enterohepatic circulation. But you have to auscultate your bowel because your charcoal in itself can obstruct your bowel. It might cause inadvertent perforation, right? Then, if you want to enhance the elimination, very underutilized is whole bowel irrigation with PEG solution. But you have to continue to give it until there is a clear rectal effluent. And it works only for sustained release preparations. We don't see body packers in our country. Iron, lithium levels. As I mentioned earlier, auscultate your bowel. You have to be watchful for bowel obstruction and perforation. The other is urinary alkalinization. So you have to start a bicarb infusion to target urine pH of 7.5 to 8.5. And the indications are also very specific: salicylates, phenobarbital, and methotrexate. Okay. Then there is hemodialysis. Now, hemodialysis is not going to remove every poison in the world. There are extra guidelines. You can search for it. The guidelines are out there for everyone to see. There is no, it's not a paid thing or anything. It works best for small molecular weight poisons, water soluble ones. So your methanols, your ethylene glycols, salicylates, lithiums, valproates, metformins. Early hemodialysis will help. What you need to remember is that with lithium and metformin, you might get a rebound after the hemodialysis. You have to monitor levels every 6 to 12 hourly, and you might need a repeat session. This hemoperfusion and plasma exchange, this is coming up very nicely in our Indian context. Especially intensivists in Gujarat and South India are like heavily using it. You will find a lot of case reports on poisonings being treated by these. Jaffran is a biomedical company. They have their own filters. I'm sure there are other companies who have similar filters. Look for it. There are 4 cartridges that you can use. So the difference is your hemodialysis will remove small and water soluble, low protein bound toxins. Your hemoperfusion is for what? Is for the poisons that hemodialysis cannot remove. Large molecular weight, protein bound, lipid soluble. Remember the HA130? It is for OP, paraquats, and carbamazepine. There are a lot of studies on this filter, especially with paraquat poisoning. In fact, Tamil Nadu government also has placed protocols in place for early hemoperfusion in paraquats and in retols. So it's out there. You can look for it. Plasma exchange will work beautifully for your TCA poisonings. There are some case reports on aluminum phosphide also, and for refractory snakebite coagulopathy. For paraquat, the major modality to be used is CRRT with this Jaffron filters. But you have to connect them in series. So it is one CRRT machine and one cartridge. But you have to start that within the 4 hours period. After 4 hours, it's essentially futile. This is for paraquat. Take a picture of this if you want to. It might help. Now we'll proceed to some of the common poisonings in our Indian context. Remember this. Take a picture of this chart, right? And I'm not going to be reading out the slide, but remember your sympathomimetics and anticholinergics both will present with mydriasis, tachycardia, hyperthermia. But skin would be your single most powerful bedside differentiator, right? So your hand essentially beats any urine drug screen. So if you have a wet skin, it's either sympathomimetic or cholinergic. If you have a dry skin, it's either anticholinergic or opioid. You have narrowed down your poisons in the case of an unknown poisoning, right? So never forget to, uh, touch your patient when you're proceeding with an unknown poison. Are you guys with me so far?
Yes,
Yes.
sir.
Any doubts?
Yes.
Yes,
Yes.
sir.
Yes. Sir.
Any doubts? Okay.
No, sir.
No, sir.
Next, sympathomimetic toxidrome. Agents, your cocaines, amphetamines, MDMA, ephedrins. Uh, I don't, you don't see it quite often. The symptomatology would be hypothermics, tachycardia, and hypertension. You will get temperatures of more than 40 degrees Celsius. How would you treat fluids, and a lot of fluids? These people will have a wet skin, and here you have differentiated from an anticholinergic. But here is also the part wherein one, don't reflexively give beta blockers just because your cardiologist said so, just because you wanted to control the heart rate. You will cause unopposed alpha stimulation, and the patient will land up in hypertensive crisis. Okay. If the patient is agitated, is having seizures, your benzos are your first line. Active cooling measures. Apply ice packs, fans, keep wet clothing over the patient. Check your CPK levels. These patients will have are more prone for rhabdomyolysis. The antipsychotics are only a second line drug management. Anticholinergics, same symptoms. Key differentiator, skin. They'll be dry. Okay, so they'll obviously be delirious, agitated. They'll have visual hallucinations. They also will be hyperthermic. One interesting part is that they don't sweat, which is why the skin is dry. So they won't be able to thermoregulate. So you'll have to aggressively cool the patient, use your cooling blankets if needed. Uh, they'll obviously be mydriatic. Monitor your ECGs and catheterize these patients because they will have urinary retention, right? Uh, they have a lot of overlap with TCA poisonings. In fact, TCAs cause anticholinergic issues. So this is this. Sludge, I think most of you have read about it. Almost all of you know about it. Uh, it stands for salivation, lacrimation, urination, defecation, GI distress, and emesis. The other lethal triad is BBM, bronchoria, bronchospasm, and meiosis. Essentially, your patient is drowning in his own secretions. So, how would you differentiate between a cholinergic patient and an opioid patient? Your opioid patient is quiet. Your cholinergic patient is drowning, right? So your opioid patients will have their CNS depressed. They will be bradypneic, and they will have pinpoint pupils. Antidote, naloxone, 0.4 to 2 mg. But you're not going to titrate it to consciousness. Why? Because full reversal will, then you'll have another problem. Your patient will be pulling every line. Now, then you'll be giving another opioid to silence the patient. You're basically catching your own tail. So titrate it to bradypnea, titrate it to respiratory rate. Okay. And you have to watch for re-narcotization. So because the half-life of naloxone is very short. So remember, when you're giving naloxone, titrate it to breathing, not consciousness. Organophosphates. I'm sure you all know the mechanism. Uh, the key points are the ACH receptor is the acetylcholine is flooding every receptor possible. Why pralidoxime must be given early? Because once the enzyme inactivation is permanent, you're not going to be helping with any dose of pralidoxime. Okay. Your common Indian agents would be chlorpyrifos, malathion, and monocrotophos. You have to see the package insert. Ask them about the package taken, right? Most of these have a high tendency and they age early. So earlier hospital attention will prevent most of the complications from it. If you see a patient with altered sensorium, profuse secretions and fasciculations, it is OP until proven otherwise. That is if you're suspecting a uh, toxin here. Any questions on this? Okay. Difference between muscarinic and nicotinic features. So your predominantly muscarinic symptoms would be salivation, lacrimation, your bronchoria and bronchospasm, meiosis, your sludge symptoms, essentially bradycardia and hypotension. Uh, these patients are atropine responsive, but if you see patients with fasciculations, progressive muscle weakness, your neck flexors will go earlier than anything else. Respiratory muscle failure, if you see predominantly tachycardia and hypertension, and the patient is already very anxious, is having seizures, uh, then they're predominantly nicotinic. Now, they come in three phases. You have to know the phases. If there is a case given in the exam, they might confuse you with the phase and they may ask questions such as, this patient is improved. Do we want to discharge this patient? So the first phase is the acute cholinergic crisis. Give your atropine and pralidoxime. But day 2 to day 4, 48 to 72 hours, your patient starts improving. You are relaxed. And then suddenly you get a call from that the patient is started to desaturate. This is your intermediate syndrome, right? So keep the patient off OP at least for 72 hours in the hospital. This intermediate syndrome, as I said earlier, your neck flexors will fail first. Your proximal muscles will fail first, right? It is not prevented by atropine or pralidoxime. You have to be watchful for it and you have to intubate the patient. The last phase comes quite later. It is delayed neuropathy. You'll have distal stocking glove neuropathy. The treatment is supportive in this case. So, key takeaway from this slide. Don't discharge your patient before 72 hours just because the patient was improving. Atropine protocol. Uh, there was a study in Sri Lanka which uh, studied for pralidoxime and atropine, and the doubling dose protocol was found to be more effective than any other protocols followed. So the doses, you load the patient 1 to 5 mg, and you have to double every 5 minutes. So you have to stand at the bedside. Suppose you've given 1 mg, stand at the bedside. After 5 minutes, auscultate the patient. Still the secretions are present. Give 2 mg, 4 mg. So essentially, uh, you might run out of atropine in your cart. So to call the pharmacy, you might require hundreds of milligrams. But don't be afraid. You have to continue uh, doubling the dose until you can auscultate the secretions to be dry. And only then you have to start an infusion, which is 10 to 20% of the loading dose per hour. So suppose your essential loading dose was say 50 mg. So then you have to start the infusion at 5 milligrams per hour, right? You cannot stop atropine because the patient is tachycardic. You do not titrate atropine to tachycardia, right? You titrate atropine to your secretions. Dry secretions is your titration endpoint. The tachycardia can have three causes. One, it could just be nicotinic stimulation, right? You have to give atropine for this. But your heart rate is going more than 150, patient is delirious, you forgot to catheterize, the patient is in urinary retention, patient has started to become hyperthermic, the secretions are dry, it looks flushed. Reduce your infusion dose by 50%. And the other cause is physiological. You've not intubated the patient. The patient is in pain, anxiety. They could be simultaneous fever. They could have aspirated. They could be severely dry. You have to load the patient with fluids. Do not give ivabradine or beta blockers in this case. Tachycardia is compensatory. If your heart rate is more than 150, if the patient looks flushed, hyperthermic, reduce the dose by 50% if you have to. But you have to continue atropine until your secretions are still wet. Okay. Use benzos, intubate the patient to manage the tachycardia. About pralidoxime, the dose is 1 to 2 gram IV over 30 minutes and then 500 milligram per hour. To give it early, before 24 hours. APRAP trial was a trial it was a well-conducted RCT from Sri Lanka. The sample size was small. There was no benefit with pralidoxime, so that is very controversial. But all the Indian guidelines and the WHO guidelines recommend giving pralidoxime. Okay, so you have to give it. If the patient has come to you within 24 hours, give your pralidoxime. While intubating, do not use acetylcholine. You will prolong paralysis. And the most important part with OPs, decontaminate. When you get a patient of OP in the ICU, remove all clothes and wash the patient thoroughly with soap and water. Give sterile water in the eyes. Each eye, flush it with for 5 to 10 minutes. So to thoroughly wash, you have to remove all clothes, throw them away, because the dermal absorption of organophosphate is quite high. It is one of the risk factors for your intermediate syndrome also. Clear so far? Any doubts?
No, sir.
You cannot mess up
No,
your
sir.
Hello.
hello, yeah.
Sir, I have a question.
Hmm. Go ahead.
I am audible, sir.
Yes, yes, please tell me.
Sir, if patient comes with the poisoning of monocrot and
Hmm.
presenting with the signs of tachycardia and other weight and breathing difficulty and all those things, so we treat him with the atropine or we should hold the atropine if the heart rate is already 150, 160.
If your secretions are wet, you have to give atropine.
Okay. And monocrot we treat as the organophosphate.
Yes, yes.
Okay.
You reduce your heart rate. Your monocrot patient will be severely dehydrated also. They would have
Okay.
tried. You'll barely get a OP poisoning coming to you directly. They would have tried all home-based remedies. They would have tried vomiting out the poison. They would have probably vomited excessively. The sludge symptom in itself says they would have had diarrhea. Your patient would be exceedingly hypovolemic.
Okay. Okay, sir.
Yeah. Shall we proceed?
Yes, sir.
Snakes. So, uh, monsoon season obviously is the peak season for the big four snakes. Russell's, saw-scaled vipers, kraits, and Indian cobra. Now, one thing that you need to remember is the distinction is not like if it's not as if a Russell's viper will only have it's predominantly hemotoxic, right? So it might help you to differentiate between the kind of snake that you are dealing with, but with snake poisons, more often than not, you're going to be treating what you're seeing in front of you. So for coagulopathics, look for uh, necrosis, bleeding manifestations. Send your panel for DIC. Do your whole blood clotting time. If the turnaround time for your TEG is good, TEG might help. But if you have crate, and why crate is dangerous is you normally there is no bite mark or the bite is quite painless. Uh, Nocturnal bites and ASE becomes less effective once the entire poison is bound, the entire venom is bound. So communicate to the family that the patient might need prolonged ventilation. Uh, One thing that you can do to differentiate between cobra and crate is give your neostigmine and atropine. So your ptosis will improve. If your ptosis improves, it is most likely an Indian cobra. If your ptosis does not improve, then it's most likely a common crate. So that is all the differentiation that you might have. So if you're not seeing any hemotoxic manifestations or muscular manifestations in a suspected snake bite, a dose of 0.05 milligram per kg of neostigmine and atropine, and if you're seeing ptosis and bulbar palsy, one dose should be given because the cobra venom is usually post-synaptic and you might reverse it. Crate venom is pre-synaptic. Your neostigmine is going to be useless, right? Same. About ASV, in our country, we don't have snake-specific poisons. Uh, One interesting incident in one of the centers was so they run a zoo and one of the workers got bitten by a snake. Now, that snake was very native to Thailand. So they flew that snake specific poison from Thailand overnight to treat the patient. I'm not naming the center, but the chances of this happening are very low in your clinical practice, right? In our country, it is one polyvalent ASV. based on the most common four snakes that I mentioned. So you might be unlucky and you might get a snake that venom that is not effective. That is not going to be treated by this ASV, but you still have to give. The dose is 10 vials IV over 1 hour. You can give a maximum of 30 vials. ASV has very high anaphylaxis rates, so keep your adrenaline bedside. And if it is a hematotoxic poisoning, you have to repeat 10 vials at 6-hour intervals if your whole blood clotting time is abnormal. Your whole blood clotting time is a bedside screen, clean glass tube, 2 ml of blood. Okay, wait for 20 minutes, invert the tube. If it is a free flowing blood, it means your patient still needs an ASV. Okay. No prophylactic blood products, no prophylactic FFPs or cryos. If you see active clinical bleeding, only and only then you have to treat it. In these patients, watch for your renal dysfunction. You can't sit overnight thinking Lasix and bicarb might do the trick. Russell's has a very high rate of cortical necrosis. So if your acidosis is worsening, if you're not getting an output even after you have given enough fluids, speak to your nephrologist, dialyze the patient, start him on dialysis. For neurotoxic poisons, uh, identify a threatened airway, nasal voice, pooling of secretions, intubate early. Okay. And no tourniquets, no incisions or suctions. And, I mentioned earlier, crate bites may not have local signs. So you have to just monitor and be prepared. There is a specific way as to how you tourniquet or, bind the affected limb. But that probably, if you take a lecture on specific snake bite, I'll mention. But key takeaways, ASVs, 20 minutes WBCT, blood products only when needed. Be watchful for your AKI. Give neostigmine atropine if no hematotoxic poisoning suspected. Watch for your muscle weakness. Okay. Scorpions, there is essentially an autonomic storm in 3 phases. Initially, you will get parasympathetic response, bradycardics. Then suddenly there'll be a massive sympathetic storm. You will have a cardiovascular collapse. So the drug of choice is prazosin. Most common cause of death is your acute pulmonary edema. Here is where you involve your cardiologist or your senior intensivist to do an echo early and monitor for LV dysfunction. Start dobutamine early. There is a scorpion antivenom available. If you see a lot of scorpion poisonings, helps to have one in handy. They're notorious for causing pancreatitis, and children have reported a much higher mortality. So, you have to be very cautious here. Not beta blockers, prazosin is the drug of choice. Paracetamol. You will see it often in a very, quite a favorite toxicological case in every exam. So you have to remember all the small details here. Toxic dose is more than 150 mg per kg or 7.5 to 10 gram in adults. This is one poison wherein you actually ask the number of tablets, see the dose of each tablet, calculate bedside, and see whether it is more than 150 mg per kg. If you have a Rumac Matthew nomogram, you can, chart it and do it. But if you know the patient has taken paracetamol and it's in this toxic doses, this is your 21-hour NAC protocol. Bag 1, 150 milligram per kg in D5 over 1 hour, then over 4 hours, 50, then over the next 16 hours, 100, 150, 50, 100. You have to give this dose, you have to complete, you cannot stop the infusion. Within 8 hours, it is 100% treatable. Monitor for anaphylaxis reactions. You can lower the rate, but not stop the infusion. Okay. Treat symptomatically. Involve your liver transplant surgeons and hepatologists here. Memorize the KCC criteria for transplant. So you have to be watchful of it. You can't delay your blood gases. You received a patient at 8 p.m. and then kal morning 8 a.m. check karenge. No. You have to frequently monitor your INRs. And if the patient lands up in grade 3, grade 4 NCAF, enough to be intubated, that is where you raise the alarm bells. This also comes in 4 phases. First phase, first 24 hours, this is where your NAC is 100% effective. Okay. The second phase comes in 24 to 72 hours later. Patient feels better. It's like OP. Patient feels better, asks to go home, but your transaminases are worsening. Okay. It is the most dangerous point. Don't even send this patient to wards. Keep him in the ICU. Because for paracetamol, everything falls apart on the 3rd and 4th day. Right. Your INR will creep up, your bilirubin will rise, you will have bleeding, you will probably be intubating the patient. Okay. You are not to stop NAC. Any doubts?
Sir, creatinine more than 300, I didn't get that, sir.
300, the different value, I think 300 milligram per deciliter
Okay, sir. Thank you.
values. Any other doubt? You have to remember your paracetamol overdose. This is one of the most favorite overdose cases you are going to get. Benzos, one poisoning toxidrome wherein you have to ask for co-ingestants. Normally, they don't just take it with water. You'll have alcohol. I have seen funny cases wherein they've taken it with acids, corrosives, toilet cleaners. They have mixed benzos and opioids in alcohol and then added, this Fanta and then cold drinks and then had it. So inquire about co-ingestants. Yeah, flumazenil with TCA co-ingestion, you will cause seizures and cardiac arrest. So if you're not sure, you don't have to give. Okay. I mentioned earlier, naloxone is to be titrated to your respiratory rate, not your consciousness. Okay. And these patients, they might have prolonged periods of immobilization. So you have to watch for rhabdo. You have to keep a watch on aspiration pneumonitis. Corrosives. More common in our country. Toilet cleaners, battery acids. Battery acids are usually sometimes unintentional. Your sink cleaners are predominantly alkalis. So most important part, no RTs. Definitely no RTs. You are not to be worried about patient ने कुछ खाया है कि नहीं खाया है. Food only and only when your gastro says it's okay to give food. Right? Keep them nil per oral. give them fluids, start your PPI infusion, give them pain relief. They're going to have massive pain. Uh, your alkalis will have predominantly esophageal injuries. Your acids will have predominantly gastric injuries. But that is for your gastroenterologist to see. What, as an intensivist, you need to see is your airway. If you see secretions, if you see stridor, uh, you have to intubate. If there is no question of the part key, there were no oral burns. A scope is always recommended, but if there are signs of drooling, stridor, their voice is changing, you are going to be having a massive oropharyngeal edema. That airway that could have been handled by conventional measures will turn to a surgical airway. Okay. So intubate early in these patients, if in doubt. And keep a very high suspicion for mediastinitis and perforation. Alcohols. In acute alcohol poisoning, don't just assume the patient is drunk. Rule out head injuries, check your sugars, and again, ask for what else have they taken with alcohol. It's normally not just the alcohol. You guys are already well aware of the Wernicke's risk, so thiamine before glucose. This is where your ABG case will also be interesting. I'm sure you've been taught that high osmolar gap with normal anion gap is high osmolar gap is essentially acute alcohol toxins, right? But that is in the very early phase. The late phase is low osmolar gap because your parent alcohol is already metabolized, right? But there, your high anion gap metabolic acidosis will be the clue due to formic acid. Fomepizole is your drug of choice. Textbooks do mention to give ethanol via central line. I've never used it. Add folinic acid. But here you have to remember that if there are co-ingestants in the history, your toxicity is going to be prolonged. And just because you have been brilliant enough to calculate the osmolar gap and you have found it to be normal, it does not exclude methanol. The presentation could be late. Blindness is one thing that you might see with methanol poisonings. Any doubts so far?
No, sir.
Other two most important ones, aluminum phosphide and paraquats. Currently, they dominate the poisoning caseload in India. So this is the mechanism. It is essentially cause a massive free radical cascade. You'll have multi-organ failures, very high mortality rate. Uh, there is no antidote for this. Garlic, fishy odor, if you're able to appreciate one single 3 gram dose, it's essentially your rice tablets, is lethal. This is where all your electrolytes will go for a toss. Your liver, kidney will fail. While managing, support the heart first. And be watchful. If there is one single 3 gram tablet, be sure that your heart is going to go. So be watchful for your sudden cardiovascular collapse. Keep your pressors ready. Keep your echo bedside. Monitor frequently. Involve the cardiologist early. This is the time. There are certain very interesting case reports, even in smaller centers. who have actually discharged patients on VA ECMO. So this is where you need to wake up your consultant and ask whether or not to initiate VA ECMO early. In fact, initiating early in aluminum phosphide, of course, there are case reports, but they have shown dramatic improvements. Patients have walked out of the ICU, right? Uh, give your magnesiums, give your bicarbs, and this is one poison wherein an honest family communication helps. You have to tell them that uh, the mortality is more than 90%. So early ECMO referral is very tricky, but early ECMO support might still be beneficial. And while managing, wear a mask. This is one poisoning, two actually, aluminum phosphide and paraquat. Always wear a mask. So then comes your retols or your yellow phosphorus. Again, this is a phased poisoning toxidrome. NAC, hepatoprotective. Again, the magic starts after 3 to 4 days. The first 3 days, everything is good, but you have to continuously monitor the patient for worsening liver functions. This is where liver functions have to be monitored at least 12 hourly. Uh, keep your transplant team in loop. Early hemoperfusion and continuous CRRT, there are case reports which have managed the patient very well. Patients have, in fact, in my center, we have actually discharged 5 to 6 patients with early hemoperfusion, early plasma exchange and CRRT, right? But it has to be a continuous modality. And then the paraquat. This is one poison where more oxygen kills, except a PaO2 till 50 mm of Hg and SATs of 85 to 90. Your nurse is going to be troubling you the entire night that saturations are 88, saturations are 86. Accept it. If the patient is not in airway distress, accept till 85, 84. No oxygen at all. Okay. This is where your hemofiltration cartridge is going to help. It is to be started, but within 4 hours. There are dosing schedules for cyclophosphamide and pulse doses of methylprednisolone. It is just going to reduce your pulmonary inflammation. But here also you have to communicate early. Some case reports with VV ECMO and VA ECMO are available, but that is very much center-based expertise. There is a urine diethionite test, quite favorite for MCQs. So remember that. It will turn blue-green and it confirms paraquat. In fact, that's how you monitor clearance. But you have to frequently, if you're using a filter for it, it's not just one session. It will rebound. So multiple sessions will be needed. So after clearance, preferably longer hemoperfusion helps with CRRT, and then you have to continuously monitor with this urine diethionite test. With the filter, you will get it. If you speak to the concerned pharmacy guy, they will give you the urine diethionite package, and the instructions are very clear. So most of the poisons are over. Any doubts so far in any of the poisons? Every poison is a separate lecture into itself. I've just given the basics. But is there anything you guys want to ask?
Good evening, sir. Sir, in 20-minute WBCT in snake bite, when we tilt the glass tube, we should tilt it up to 45 degree only, or the blood should clot full 90 degree, we should revert the bottle, because sometimes we see till 45 degree blood seems like it has clotted, but when we turn it down completely, then the blood it looks like it
Complete
had
turn it
not
down.
clotted.
Complete turn it down. You have to be sure. You have to be sure because if you complete turn it down, because if you think the blood is clotted enough and when you turn it down, it is completely watery, you are missing giving ASV. It's a
Okay, sir.
complete inversion.
And sir, you have said if it not clotted, then every 6 hourly we should repeat 10 vials of ASV.
Yes.
But you also have said that maximum 30 vials. It was just for the bolus type words you said.
No. That is the recommended maximum dosages. So 6 hours, 10 vials, I mean for 18 hours, that covers your 18 hours. That is what most of the studies have shown that by 30 vials, so each vial of ASV is going to neutralize around 4 to 6 milligrams of anti-snake venom. And your Cobra is not going to be releasing more than 145 to 150 milligrams of venom in a single bite. So that is where the dosage of 30 comes into play, which is why giving more than 30 is of no use because whatever neutralization power you have had with the amount of circulating toxin, you have already exhausted. Then it's just supportive care.
Thank you, sir.
Remember the organ complications. Watch for aspiration pneumonitis. It could have a very delayed presentation. You could have withdrawal symptoms, post-hypoxic NSAIDs. You could have seizures. Always in any poison, send your CPK levels. And your ECG monitoring is a must. You will be surprised QRS widening of more than 100. We recently had a patient who had taken multiple dosage, and we were not sure as to what. She's a long time psychiatric patient, and we were not sure of the toxicity. But the QRS was more than 140. The supports went after bicarb loading and infusion, supports went down from 30 of NORAD to no of NORAD in almost 24 hours. In fact, we have even discharged that patient now. So you have to sit down with the primary and explain that QRS more than 100 is sodium channel blockade, and the only treatment is bicarb loading. The other thing two more things that I want to stress upon is if you are someone who manages pediatrics, give weight-based dosing. They have more hypoglycemia risk. They have very less reserves. Elderlies are not weaker patients. It's just that their clearances are reduced. But you have to keep a watch that they would decompensate faster. Again, very less reserves. So don't admit these patients in the wards at all just because they look stable. Admit them for 72 hours in the ICU. And pregnant patients, treat the mother. If you're not treating the mother, you are not treating the fetus at all. You cannot hold any antidote just because you think the fetus might be harmed. If the mother is harmed, the fetus anyways is not going to make it. Okay, so you have to give antidotes in poisoning patients if you find pregnant females. The most important point is psychiatry referral. It is an essential management step. Your responsibility does not end just because you've treated the patient. It is your responsibility to actually prevent a second similar incidence with the same patient. And also, it has medical legal implications. So, psychiatric assessment is a must before you discharge before that patient walks out of your door. Take a picture of this. Your MCQs, this is your exam goal. You have to know the dosages and the infusion point. Before I end, my only takeaway from this, my only key point that I want to stress is knowing your antidotes is good, but it is not a replacement for good ICU care. Your 90% of the outcomes will depend on how you manage your ABCDs. Don't forget to touch the skin and no blind arteries in your corrosives. Don't stop atropine just because there is tachycardia. Don't forget your CPKs and ECGs. Any other questions on this? I'm ready to take. I think we've exceeded the time limit, but yeah.
Good evening, sir.
Yeah.
Sir, two questions. What is your take on the phenyl poisoning which we see frequently in Indian ICU? Should we go for the RT or not? And what is the prognosis for paraquat poisoning?
Phenyl, no RT.
Okay, sir.
No RT at all. I recently came across a case wherein there were some people